All right, so today we're going to talk about pediatric resuscitation. All right, so we've talked about quite a few things already in terms of shockable rhythms, non-shockable rhythms, and hopefully next week we're going to have like an interactive session. I'm hoping it will be interactive, where you guys will need to tell me how we're going to go about doing all of these things. All right, but just before we do that, we just need to have a look at pediatric resus, because it's a little thing on its own that's probably one of the most difficult things to do. It really is one of the scariest things that you can face as a doctor. How many of you guys out there, parents? I'm guessing a few. The thing is, children are not just tiny humans, and when a child gets injured or gets hurt, and as a parent, you bring that child in, morning, T. How are you? Sorry, I only saw your chat now. The thing is, as much as they represent a patient at that point, but to the family, even to yourself, to everybody who's around, children represent hope. They represent the future. They represent our dreams. You plan out a whole life for your child. You become a better person for your child. You do so much for your child, and you have so much invested in that child. And when you see somebody's child not doing well, in fact, dying, is one of the scariest things you can face, because it's not just a human being passing away in this case. It's that little bit extra that's added on in terms of, my God, these people are going to lose so much if I don't do this well, and that's what makes it so scary. It also makes it emotional, because we are human at the end of the day, and we all see children in that light, So how do we do it? Now, the thing is, not much changes, all right, in terms of what we've talked about before. We always start with the CABs, all right? So compressions, airway, breathing. And the only difference being that compressions are going at 15 compressions to 2 breaths, all right? Now, a lot of people may wonder why. It's not because of the heart size of the child. It actually has to do with the reason for most children going into cardiac arrest. Generally, children don't go into cardiac arrest for cardiac reasons. So in other words, it's not for myocardial infarctions or even pulmonary emboli or anything that has to do with the heart, the valvular disease, all of that. They generally go in because of respiratory causes, hypoxic causes. So they can't get air into their lungs, and they go into this hypoxic cycle, which is a nice thing to read about. It's basically like a death spiral that they go into, and how it affects the myocardium. And eventually what happens is the heart just goes into a standstill or a fibrillation. So what you're doing by doing 15 to 2 is that you're actually increasing the amount of oxygen that you're getting to them. And their hearts are very resilient. So a lot of the time they'll actually come back from that. Okay. And like I say, if you'll have any questions, just stop me at any time. All right. So these are the compression techniques on a small infant or a small toddler. All right. So for a small infant, we just place 2 fingers along the bottom of the xiphoid, and you press to about 1/3 depth of the chest, and about 100 to 120 beats per minute. So like we said, staying alive, staying alive. You just got to keep on doing that. This you do the 2 thumbs method if you can get a good encirclement. So if your hands can't fit properly around, then you don't do that. Okay. So the reason I mention this is because when we're doing adult resus, because you've got 2 hands, it requires a lot of effort and movement. Adult resuses look very busy, whereas pediatric resuses are generally quiet. I mean, you can do this while you're sitting down. You can do it for hours. It's not going to change anything. So it's good in a way, because children require a longer time for resuscitation as compared to adults. And they generally have to be given more of a chance than what an adult patient would be given. Okay. All right, let's see what's next. All right, so, and that's for a slightly older child. Now, when you're talking about between 7 and 10 years old, so sorry. Let me just go back one. Yeah, so that's the technique that you use, of a single hand, right? So once they hit about 11 or 12, then you use 2 hands, right? Just remember not to crush the rib cage, okay? And then ideally, you should only do compressions for 2 minutes and then switch around. In children, you can carry on for a little bit longer, especially with the infants and the toddlers, because you don't really run out of strength that quickly. But as soon as you feel yourself becoming ineffective, that's when you really should swap around with somebody else. Okay. All right. Hope everybody's got that. So that's just the compressions. Now, we are lucky in that we work in an organized, well, when I say organized, as organized as it can be. But you have to organize yourself very quickly into specified jobs whenever you're doing any sort of resuscitation. And we had spoken about this before, right? So somebody, we know who's going to do the drip. We know who's going to do the airway. We know who's going to be doing the compressions, who's going to be the team leader, things like that. And this is one of the most important things when it comes to resuscitation. Stay calm. Do what you know. So if you don't know how to do something, for example, in pediatric resuscitation, they talk about a needle insufflation, all right, where you put a needle where you would normally put a cricoid. You've got to have a wide tube and you've got to have a specific PSI. If you read about it once in a book and you don't know how to do it, don't decide to experiment on a child that you can't intubate, for example, all right? Do what you know how to do. So if you know how to put an LMA, put an LMA, all right? Take it one step at a time. So even if you miss something, you forgot to give one dose of adrenaline or you forgot to give one dose of something else, don't panic. Stay calm. If something is given in excess or something is given in a lower dose than expected, just stay calm and continue from where you are. The problem is that whenever we panic, you know, I like to give the analysis of a computer screen. All right, when your desktop is nice and neat, it's nice to look at it because you know where everything is, even if you can't spot it immediately, but you know more or less where to look for it. Once panic sets in, it's kind of like having a messy desktop. And now when you need to find information that you really need, it becomes very difficult to pick it out from here and pick it out from there. So regardless of anything else, if you stay calm, you will do the best job that you can do. Once you start panicking, that's the end of it for the patient and for you, all right? So the most important thing with kiddies is that we need to check the weight, because you're not going to treat a two-year-old the same way that you treat a 10-year-old, all right? So there's a few ways that we can check. So there's age estimation, all right? There's parent estimation. There's Broslow tapes, if you've ever seen. And today I'm going to show you the Pauper tape, which has 94% reliability. Now, the Pauper tape, they're readily available in South Africa. In fact, ours just got used up, so I need to order some more. They didn't have. Age estimation is actually the age times 2 plus 8. All right. So for example, if a child is 2 years old, you say 2 times 2, so that's 4 plus 8. So it should be around 12 kilos. If a child is 5, 5 times 2 is 10. Plus 8, which gives you 18. All right. So it's it can give you an estimate, but it's not that reliable in that not every 5-year-old looks exactly the same. Not every 7-year-old looks the same. I mean, my 5-year-old stands about 10 centimeters taller than everybody else in his class, and he's got a big stomach, you know, so he's not going to weigh the same as a small little 5-year-old girl who sits next to him, you know, and looks about half his size. But at least it gives you something to go on. All right. A parent estimation is much better. So most of the time, parents have been going with their children to the clinics, to doctors, to have checkups. So they'll have a bit of a better idea. The Broslow tape we all used to use before. It was that long, thick tape with all the different colors on it. And it's also quite reliable. But the most reliable they found is the Pauper tape. Now, the Pauper tape was actually a South African invention developed by some of our doctors here. So I'm going to show you a small video on the Pauper tape. And then you know, you can just have a look at it and see. The only thing I want to change is just on the audio. Don't think it'll give me a chance to do that now. Oh, wait, maybe I can do it here. Okay, you guys must just tell me if you can hear it or not. Okay.
2 people. So let's begin with the Pauper XL tape.
Can you guys hear that okay? Somebody can just give me a thumbs up or something on the chat. If you can't hear it, let me know as well. Let's just try it a little bit more.
We will first demonstrate how this
Let's have a look and see. Okay, thanks. All right, thanks, Susan.
technique is used with one person in a supine child. In this video, the tape is being shown used on the opposite side of the child to the investigator. It would normally be used on the same side so the tape can be clearly seen.
Align the start of the Pauper XL tape with the top of the child's head. Ensure you're using the side that says measure from this line. Stretch the Pauper XL tape down the side of the child's body. Do not follow the contours of the body, but rather keep it straight. Take note of where the Pauper XL tape crosses the child's heel. This child falls into the 30 kg ideal body weight segment in the green color zone. An important part of the Pauper methodology is to adjust the weight estimation according to the child's body habitus. The Pauper XL tape has a companion figure reference image guide to assist with this. This child matches the habitus score 2 images. The Pauper XL adjusted body weight is therefore 28 kilograms for this child with a habitus score of 2.
Just going to stop it there. So I hope you guys saw the lady who was presenting over there. So the lady who was presenting over there is Professor Lara Goldstone. And if you ever do emergency medicine in Johannesburg, she is head of emergency medicine, basically in the whole Joburg circuit. So she and one of our other profs in Johannesburg actually developed this tape. Now, in South Africa, we used to just have the Pauper tape. It used to just have about 3 up till number 4 or 5. So basically, what it does is by length, it tells you the ideal body weight. And then if the child is smaller based on the habitus, so in other words, a very thin child, and then you would go like 2 above. Now, the reason why they're marketing the Pauper XL is actually for the UK and for America, where they're trying to break in. So where they have McDonald's syndrome, unfortunately, and you have kids that are absolutely huge, that's why they've got the Pauper XL. And luckily in South Africa, we don't need it, but it's a nice thing to have if you can. So once you've got the weight, the question is, what do you do? Now, this is called a pediatric waffled card, all right? Pediatric waffled card. The reason why we call it a waffled card is because it actually gives you everything that you need. For example, now there's 9 of you here. If I had to ask you, give me the dose of adrenaline that you'll need in a resus for a 3-year-old. Number one, it'd be very difficult for any of you to give it to me off the top of your heads. Number 2, you'd first have to guess the weight, then go and try and work it out and do things like that. And then plus on top of it, I need to know the size of the ET tube. I need to know how deep the ET tube can go. I also need to give the child dormicum. I need to do a lot of things. So what happens is that we, like in our situation, we have these waffle cards. And I would suggest that in any emergency department that you have, you work on these too. And if you need them, tell me, I'll send them out to you as well. So I'm just going to give you an example of what it looks like. All right. So what it tells you is that if you have a child who's 7 years old, your weight will be approximately 22 based on the age estimation. All right. And you can see after 8 years, it's actually the age times 3, not age times 2 anymore. That was something I had forgotten. But whatever you use, so like on our waffle, it has the age and it has the weight. So let's say, for example, the patients tell you the child is actually 5, but the parents tell you he's 22, then you would use the 22 kilo. So what it does is it tells you how much of adrenaline. So adrenaline in kids, we give 1 in 10,000. What it means is that we take 1 m, dilute it with 9 mils normal saline, and that mixture we give 2.2. Okay. Fluid, if we want to bolus, we can bolus 440 mils. If we need to give use an ET tube, we're going to ask for a 4.5 cuffed or 5 uncuffed. How deep are we going to go? 14 to 15 centimeters. If we need to shock, we can go from 100 to 200. If we need to give dextrose for hypoglycemia, we have to dilute it according to this, and then we get 22 mils. What is deadly shock? In other words, what is the systolic that we are worried about? In this age group, it is 84. So if this child has a systolic of less than 84, we consider this child to be in severe shock. Okay. If we had to give calcium, how much would we give? If we are doing any sort of procedures, how much of ketamine, how much of domicum would we use? If we need to intubate, how much of sux, how much of rocuronium? So it's almost impossible to keep all of these things in your mind, you know? So Valeron, morphine, pethidine, Valium, Ativan, domicum, how much of Panado? So by keeping this on hand and keeping it in your resus area, what happens is that one person from there who knows the weight picks out the chart that's corresponding to that weight, and whatever you need to know is already on there. Right? There are certain things that you can learn off from here that you can know, and as you do more pediatric resuscitations, you get the hang of them. But everybody needs to. Now, there are copies of these available online. If anybody here was working in an emergency department would like my copies, just email me. Okay, what I'll do is that I'll put the cards on the group. Okay, so whoever wants them can use them. All right, it's not a problem. We go from 10 kilos to 40 kilos. Okay, and then beyond that, you kind of treat them as an adult. Okay, so the problem is that we want to avoid mega dosing. So as we were saying, you know, like this is the pauper tape that we would use, for example. So for this child's length, the ideal would be 14 kilos, all right? But let's say we have a very undernourished child. We could have a 12 kilo, 13 kilo, even a 17 kilo kid. The problem is if you give too much of adrenaline, for example, to this kid, you could kill him. And if you give too little adrenaline to this kid, you're not going to be treating him at all. All right. So that's why we have to try and get as close to what we need in terms of the actual what you call it, in terms of the actual weight of the child. All right. Because, for example, if we're going to give adrenaline, here we're only giving 1.2, here we're giving 1.5, you know. Here we can defib to a maximum of 120. Here we can go up to 150. Okay. And the problem is that if you don't give the correct dosages, you're going to increase the mortality because you're either giving too much or too little, you know. It's like a patient coming in and you suddenly give them 30 milligrams of domicum compared to 15, and then the patient dies. I mean, it's simple mega dosing. All right. Now, in children, what are the danger signs? In other words, what should you worry about? So the systolic, all right, less than 70 plus age times 2. But if you have the waffle cards, it works it out. All right. Any child that has a bradycardia is close to death. Any child that has a tachycardia may not be close to death, but does need further workup. All right. Those that are bradypneic and those that are tachypneic. Okay, those are danger signs. Bradypneic is more worrying, as with bradycardia, because they're coming closer and closer to death. They're going to soon go into cardiac arrest. Okay, slow capillary refill, skin changes we have all seen. All right, any change in the level of consciousness for a child. To be dead honest, I get worried if the child is even drowsy. You know, the child is just kind of looking at you but not responding. You need to be worried. Okay. And of course, if the child is unable to walk, okay, there's something that's worrying over there. So let's get on to the airway for the child. So the top one is what a normal adult airway looks like. Okay. Now for a child's airway, once you get the laryngoscope in, they tend to have more of a circular one. It's called an omega epiglottis. All right. So this is the difference between the two. And as you can see, the vocal cords are not very much different to an adult. All right. You can't see the adult one so well over here, but intubation is not that much harder in kiddies. The main reason why people get it wrong is because they don't position the kids properly, all right, which I'll show you guys in a little bit. I mean, these are all the things that we know how to use. The type of mask, we use a round mask, so it fits better on for kiddies. And the most important thing is that if you don't have a kiddie bag, make sure the pressure gauge on your bag is at least opened up. Otherwise, you're going to give them barotrauma of their lungs. Okay, right. So this is positioning. So what happens is we need to try and not flex their heads, because once you flex their head, it actually brings their trachea extremely anterior. And that's why people struggle. So what they do is they do what they're going to do with an adult, which is push that down. And then suddenly you can see the chin is going to move up and it's going to draw this whole thing sort of straight. And now what happens is your trachea is sitting more or less here where the wide is, instead of sitting where it should be for you to be able to see. All right. So what we do is we put up a shoulder roll, we put up a headrest. And the easiest way, without worrying about other things, is just to make sure the nose and chin are in line, and that the earlobe or the external meatus is in line with the sternal notch. Right? So you have these two parallel lines. And once you've got that, that's when you're going to see it quite easily, all right? Because it creates a little bit of a flex instead of an extension. And that's when you'll be able to see it. Because what happens is your laryngoscope goes in. And remember, your laryngoscope for a child is not curved. So you're not trying to get around a curve. You're actually just trying to get there and move that, because that's where your chords are going to be. Now, it doesn't matter how much I explain it to you, it's going to be difficult no matter what, especially the first time that you try and do it, all right? So if you struggle, the other thing to use is a laryngeal mask airway, because the most important thing is get air into the lungs. It doesn't matter how you get air in, just get air into the lungs. Okay. Now, for those of you who haven't seen a laryngeal mask airway, let's have a look. Very short video on how you actually insert it.
Inflate the cuff of the LMA to ascertain that the balloon does not leak. Deflate and lubricate the cuff. The patient's neck must not be hyperextended or hyperflexed during the procedure. Hold the LMA with the dominant hand as you would a pen. Pass the LMA behind the upper incisors. Push the lubricated LMA into position along the palatopharyngeal curve, with the index finger maintaining pressure on the tube and guiding the LMA into the final position. Inflate the cuff with the correct volume of air as indicated on the shaft of the LMA. Check the placement of the tube by observing chest excursions with ventilation.
So you can see an LMA is actually extremely easy to insert. It's not difficult at all. And the nice part is you can ventilate through an LMA. It does protect you against aspiration if it's placed properly. So don't get scared of using LMAs. That's 10 times easier than intubation. Rather, make sure your child is getting air into their lungs. Okay. All right. So as with you make sure, with adults, you don't overinflate or overventilate. The same thing with kids. They're a bit more prone to cerebral vasospasm if you overventilate them, and then they start getting hypoxic brain injury. Okay. So just give one every 4 to 6 seconds. Now, here's one that people always ask: how do we get pediatric drips? All right. So this is a nice little thing if you want to screenshot later. Kind of shows you all the places where you normally do find veins, all right, for kiddies. But with the kiddies, either the vein is there or it's not there, and sometimes when you're in an emergency position, you can't waste time trying to go through finding 5, 6, 7 veins, all right, because you need to get medication in now. Let's say, for example, the child has a full cardiac arrest, asystole, or is fibrillating, or whatever it is. You don't have 5 minutes to actually go and get up a line. You need to have a line up now. Okay, so if you can get a line up there, great. But what happens if you get this child? The chubster, or you get the severely dehydrated child? How long do you think it's going to get you to get up a line on these kids? I mean, you can stand for hours in a NICU if they eventually ask you to put up an IV drip, and CVP in children is difficult. It's not easy even at the best of times. So it's not really an option. So the best option, especially when time is crucial, is intraosseous access. Okay. So this is intraosseous access. Now, more in South Africa, we have the EZ-IO. Now, this is what it comes in, all right? So it's a very simple thing. This is the driver. These are the 3 sizes of needle. So that's the adult needle, normally used in the shoulder. The blue needle, which can be used in bigger kids and adults, and it's generally used in the shin and a few other places. And this is for your pediatric patients, all right? So this is normally used in the tibia, can be used in the femur or the shoulder as well. This is just a pressurized short line, to put it that way. And this is the fixation device that they give us. So the only thing it's got is just a little extra ring over here that actually helps to hold your needle in place so that it doesn't come out of place over there. So I think we've just got a video showing us a bit of it. Let's have a look.
Critical judgment should be used to determine appropriate needle set selection based on patient weight, anatomy, and tissue depth overlying the insertion site. To facilitate selection of the correct length needle set, tissue depth over the insertion site should be assessed prior to selection of the needle set. Press your thumb or finger over the insertion site to estimate the depth of soft tissue. With the needle set tip touching the bone, the 5 mm mark must be visible above the skin for confirmation of adequate needle set length prior to drilling. If the needle set is inserted through the soft tissue and does not reach the bone, or the 5 mm mark is not visible above the skin with the tip of the needle set touching the bone, the needle set is too short. A longer needle set or alternate site should be chosen prior to penetration of the bone cortex. Using a needle set that is too short will increase the risk of catheter dislodgement, leading to extravasation, create a hole in the bone unnecessarily, and render the site unusable for future IO access for a minimum of 48 hours. Appropriate needle selection as evidenced by the black 5 mm mark visible above the skin when the tip of the needle set is touching the bone prior to drilling. Extend the leg. Prepare the site by using antiseptic of your choice. Use a clean, no-touch technique. Insertion site is approximately 1 cm medial to the tibial tuberosity, or just below the patella, approximately 1 cm, and slightly medial, approximately 1 cm, along the flat aspect of the tibia. Pinch the tibia between your fingers to identify the center of the medial and lateral borders. Remove the needle set cap. Stabilize the extremity. Aim the needle set at a 90-degree angle to center of the bone. Push the needle set tip through the skin until the tip rests against the bone. The 5 mm mark must be visible above the skin for confirmation of adequate needle set length prior to drilling. Gently drill. Immediately release the trigger when you feel the pop or give as the needle set enters the medullary space. Avoid recoil. Do not pull back on the driver when releasing the trigger. Hold the hub in place and pull the driver straight off. Continue to hold the hub while twisting the stylet off the hub with counterclockwise rotations. The catheter should feel firmly seated in the bone. Place the stylet in a sharps container. Place the easy stabilizer dressing over the hub. Attach a primed Easy Connect extension set to the hub. Firmly secure by twisting clockwise. Pull the tabs off the dressing to expose the adhesive, then apply to the skin. Aspirate for blood bone marrow. Inability to withdraw aspirate blood from the catheter hub does not mean the insertion was unsuccessful. Consider attempting to aspirate after the flush. Site placement can also be confirmed by ability to administer pressurized fluids and noting the pharmacologic effects of medication administration after flow is established. Flush the catheter with 2 to 5 milliliters of normal saline. For patients responsive to pain, please visit www.easyiocomfort.com for additional information. Connect fluids if ordered. Infusion may need to be pressurized to achieve desired rate. Assess frequently for any signs of infiltration, extravasation, or other complications. Compartment syndrome is a serious complication that can result from unrecognized infiltration, extravasation. Remove extension set and dressing. Stabilize catheter hub and attach a Luer-Lock syringe to the hub. Maintaining axial alignment, twist clockwise and pull straight out. Do not rock the syringe. Dispose of catheter with syringe attached into sharps container.
Okay, I hope everybody saw that. So it's not a difficult thing. I mean, T, we did one the other day. So was there, I think you did with me as well. So, it's quite an easy thing to do. Okay. So this is just telling you the same thing, all right, more or less. And the most important thing is to make sure that once you've got it, if you just insert it and try and get fluids in, it will never happen. You have to flush. So I normally give at least 5 to 6 mils, even in kids, to make sure that you break that medullary space nice and wide open, so that the fluid can flow. And in adults, I've used up to 20 or 30 mils sometimes, just to be able to get adequate flow. And another good trick is to put your bag on the highest drip stand that you can find, because that also helps. The gravity helps quite a bit. Okay, so and this is just what I meant, so no flush equals no flow. All right. So what you're trying to get through is you're trying to get through there and then force it into the vein from there. And it works extremely well, because what's going to happen is it works exactly like an IV line. So as soon as you give your medication, it's like a split-second difference between IV and IO. So try and use it. Okay. So to see if you've got the set. And these are most of the complications that happen. So if you go too far through the bone, then eventually you will start extravasating and get compartment syndrome. It may dislodge if you don't watch for that 5 millimeter mark. Fractures can occur. So failures do occur as well. And sometimes there's too much, patients can have severe pain. It's true. And there are times that the patients get quite serious infections as well if aseptic technique is not used. Okay. So this was just one thing that I also wanted to bring to you guys' attention. In trauma, all right. So when we get patients who come to us, who have either gone through a shockable or a non-shockable rhythm, and kiddies especially. But with trauma, once we get any patient back, there's still 3 more killers that you have to worry about, okay? And I think the most important for us initially is hypothermia, then coagulopathies, all right, and then metabolic acidosis, okay? So the 3 are all interconnected, all right? If you have metabolic acidosis, you have decreased myocardial performance, which exacerbates the hypothermia. Hypothermia halts coagulation, so you get a coagulopathy, which further, increases the lactic acidosis. So it's a lethal triad that actually, kills your patient off. So the thing is, you have to break it at 1 or 2 points. So the easiest one is hypothermia. So that's why we always put bear huggers. We're trying to keep the patients as warm as possible. Coagulopathy is either by using FTPs or trying to give them things like cyclocapron, or give them platelets if needed, all right? And of course, metabolic acidosis, we often treat just with fluids, and if worse comes to worse, sodium bicarbonate and things like that. So that was just something for you guys to realize. So in summary, we need to do our CABs. In children, the most important thing is the weight. So you have the right dose, the right equipment. Otherwise, compressions, airway, ventilation, H's and T's. Make sure you don't have hypothermia, coagulopathies, or metabolic acidosis. Reverse what you can. In other words, if there's things that you can put right, put them right, and know your limits. If you've reached the stage where you don't know what to do, ask. Rather ask instead of losing the child. Okay. All right. So that's just something to finish off and just have a little joke. The other thing I just wanted to say, one of the hardest things you have to do as a doctor is, what if it's not going well? All right. What if this kid is, no matter what you're doing, no matter who's there, even if seniors are there, but this child is not doing well. You can see this child is not going to make it. The question is, a question that's always asked, especially in ethical situations now, do you call the parents or do you not call the parents to see? The first thing that you need to do, number one, the worst thing that you can do is leave the parents in the dark while everything is happening. So what we normally do is we put the parents very close to our resus bed, and one of the nursing staff is actually in charge of relaying information from us to the parents. They're not looking at what we are doing, but they are getting, okay, listen, this is happening, that is happening, this is happening, that is happening. And if things are not going well, the parents start to hear it, all right? If things really start to go down, then what happens is normally the most senior doctor will just exit from the resus, go and speak to the parents, but explain to the parents that things are not going well and give them the choice. Do they want to come and say goodbye to the child? It's one of the hardest things you'll ever have to do, but Do they want to come and say goodbye to the child, or do they not want to? Now, there's a lot of things that can affect that: culture, preconceived notions about hospitals, personal beliefs and things like that. So you don't make their decision. You merely you merely ask them what they would prefer. If they say they want to come and see the child, clear everything out, except for somebody doing maybe light chest compressions and doing a bit of ventilation. All right. Now, this is once you've realized things are going very bad. Let them come, let them have their time, because this is the last time they're going to see their child alive, with any sort of life. It's still having a heartbeat, still having a bit of breath. So let them have their time. Even if it takes them 15, 20, 30 minutes, you allow it. Don't give up your resuscitation too quickly. I would say for any child, go for at least 45 minutes before you decide that really we're not getting anywhere with this child. And should the parents or the grandparents, whoever it is, decide no, they don't want to come, then be dignified about it too. Call it quickly, let the child pass, or if the child has already passed, so be it. And then take the family aside, use the child's name and say, listen, we tried, this is what we tried. And, let them know in straight language. Don't say, things like your child is no longer with us. Well, they say, oh, okay, must have gone to the ICU, or your child is in a better place. Maybe they transferred him to Mediclinic. No, you use the words death, died, things like that. Be straight with your language. Okay. And then there's two ways of three ways that you can actually give it. Number one, you can be absolutely aloof and just be, I'm Dr. So-and-so, your child came in, unfortunately, there was nothing we could do, and I'm sorry to tell you your child has died. Now, that's extremely aloof, and it doesn't really help, right? So the best way is and the worst way to do it is, to make them feel sorry for you. Like, oh, I tried everything. I feel like I lost my own child. I'm never going to get over, to the point where the family is holding you and saying, oh God, doctor, we're sorry, and things like that. So you don't want to do that. You want to be in between, which means you want to be empathetic towards them. You want to tell them that this was something, they need to know that you cared for their child. So that's why you use the name. You explain to them what you did. You explain to them that you are sorry that you couldn't do more. And you leave it at that. If they want to hold you, let them hold you. But after a while, allow yourself also to move along. And there's many times that many of us from here have had to go out and cry in the parking lot and even take the rest of the shift off. And it's good to debrief the team, because whatever trauma you are feeling, everybody is feeling. Okay. All right. I'm not sure if anybody has any questions or anything else that they'd like to know, or everybody was happy. Okay, let's see. I've got one on the chat. Go to a better place, Mediclinic. Yeah, no, it's true. That's what happens. It's quite true. If you use very vague language, like your child is gone. Then you say, we're gone to the X-ray, gone where, so you have to be quite direct. You really have to be quite direct. That's just a bit of ethics thrown in at the end. So anyway, I hope you guys enjoyed it. I hope you guys learned something. It is something that you have to practice and do on a regular basis, and you get the hang of it. It's not possible to teach you these things practically, but next week what we're going to do is, like I say, we'll try and have a little bit of a practical demonstration in that I want you guys to participate and tell me what you would do now, based on what we can see on a patient. Okay, so try and get your research skills up to date, and then we're going to do something that's called a mega code. So mega codes are normally seen in ACLS, in the diploma for emergency medicine, where you're going to handle what really happens to patients while they're on the floor with you. Okay, but otherwise, thank you, everybody. I hope you all enjoyed it, and we'll see you again next week. Okay, bye.